Hello, thank you for joining us for our online 2-hour radiology review through First Impressions Dental Assisting Program. First Impressions is an ADA Commission for Dental Continuing Education provider, so you will be able to use this course certificate as proof of 2 hours of continuing dental education. This is an online format, so what you'll do is watch the lecture. You'll take the quiz at the end, and then you will be emailed your 2-hour certificate. My name is Carrie Gossard. I am a DANB registered dental assistant and an expanded functions dental assistant who also carries a radiology license. My goal today is to help you to remember a few of the things that you've learned about radiology and to give you some helpful hints and techniques on how to take excellent x-rays. By the end of today's course, you will have a refreshed knowledge on how x-rays are formed within the tube head and grasp the potential health effects on our patients and how to minimize risks even when we are using the low radiation emitting digital radiology that most of us are using in our modern dental offices. We'll talk about current laws and mandates related to us as a dental radiographer and when and where we can take x-rays. We'll discuss techniques and technology with a strong emphasis on infection control and 3D cone beam imaging software. Once you are finished with this course and are provided with your 2 hours of continuing education certificate in dental radiology, and again, this will be emailed to you, you will be eligible to renew your radiology license. To do this, you will go to elicense.ohio.gov and click on the center red button that says Login or Create Account. Because you already have an account, you will simply log in with the same login, the username and password that you originally created. Now, if you can't remember what your login information is, you will then need to call the Ohio State Dental Board and ask them to help you reset that login information. Unfortunately, we can't access that information for you. Anyway, you're going to log in. Once you get logged in, you will go to Upload Documentation and you will upload the 2-hour certificate. Now remember, every dental assistant, regardless of when you initially got your license, will renew your certificate every even year. Just a little helpful hint, when you go to log in as an existing user, if you've forgotten your username and password, if you try it a couple of times, it will lock you out of the dashboard for a good 15-20 minutes. So I would simply try it once. If you can't remember what your username and password are, then go ahead and call the help desk through the Ohio State Dental Board so that you can reset that information. Once you get your login and password, you'll just simply click on Dashboard to click the option of Upload Proof of CE, and that's where you will upload your 2-hour certificate. Now let's review the basics of dental radiology and the physics behind it. Over 120 years ago, a Bavarian physicist named Wilhelm Conrad Röntgen was experimenting with a cathode ray and was able to utilize that technology to create the very first radiographic image of his wife's hand. About a month later, Otto Walkhoff was able to take the first dental x-ray, and it took over 25 minutes to take that single image. Let's review some physics to refresh our understanding of what happens when we push that exposure button. To understand the physics of something that we can't see, it's helpful to look at this electromagnetic spectrum. It shows the range of frequencies or the spectrum of different electromagnetic radiation levels and their wavelength. Wavelengths are measured from the peak of one wavelength to the peak of the next wavelength. Reading from left to right, you'll see the radio waves, microwaves, infrared, visible light, ultraviolet, X-rays, and then gamma waves. The waves on the left side are far apart, and as you move down the spectrum to the right, they get closer together. To better understand this, we compare it to a day at the beach. On a calm day, you can sit at the water's edge and let the water wash gently on you, and it's quite relaxing. This is because the waves are far apart or have less penetrating power. If you do the same thing during a storm or after a hurricane, those waves come fast and furious and are strong enough to knock you down or to create ionizing energy. This is not so relaxing. Moving to the right of the spectrum and increasing in penetrating power, it goes from microwaves ranging from 1 meter to 1 millimeter in wavelength, to visible light where we start to see color, to ultraviolet where we have our UV rays, to X-rays where our dental images are created, to gamma rays which are produced when we disintegrate radioactive atomic nuclei and the decay of certain subatomic particles. So the further you go to the right, or the closer to the peaks get to each other, the higher the penetrating power, or the higher ability to create ionizing energy. Anytime energy is being carried by a wavelength, it has to land somewhere on this spectrum. When you sit in your car, you don't have to put a lead apron on when you turn on your radio or brace yourself for a powerful force because the wavelengths are long and so the penetrating power is minimal. The fact that we can walk around without constantly thinking about wavelengths is proof that there is no weight and no mass to the energy that the electromagnetic spectrum carries. Let's think about what you are exposed to on a daily basis. Even on a cloudy day, there's still ultraviolet rays, infrared radiation when you're using your TV remote. Microwave should be contained inside your microwave itself as long as it's not damaged. But what about your cell phone? Where do our cell phones lie on the electromagnetic spectrum? So often I see people carrying their cell phones in pockets close to reproductive organs that are rapidly producing cells and are susceptible to harm when it comes to radiation. Where do you think they fall on the spectrum? Cell phones actually fall somewhere around the radio waves, which is the length or width of an atom. So not very much penetrating power in a cell phone. However, it still makes me wonder if the constant exposure will have adverse effects on us down the road. What do you think? When you take x-rays on patients in a dental office, there will be times when you get pushback from a patient that doesn't want x-rays taken. This response comes from the fear of excess radiation, which is not invalid. We know that radiation can cause harmful health effects. What the patient might not understand is that we are exposed to radiation every day, from radon in the soil to cosmic rays from outer space, nuclear testing. We live in a biodome. The world is like a snow globe. Whatever happens on the other side of the world can affect us indirectly here. For a full mouth series of dental x-rays, which is about 18 x-rays, to receive the same amount of radiation, you would have to take a 5-hour flight at about 30,000 feet, which is about from here to Miami. Not a long flight, and you're receiving the same amount of radiation. In a report done by the EPA and National Council on Radiation Protection Measurements, there are all these different things that you are exposed to that present a risk to your health. You will notice that there are measurements on this slide like sieverts, whether they are millisieverts or microsieverts, but this is how we are measuring the amount of radiation. So for an intraoral x-ray or one single x-ray, it's 0.005 millisieverts. We double that for a panoramic x-ray. 0.1 of a millisievert for a chest x-ray, 0.2 for a CT scan in the dental world, 0.4 for a mammogram, and a full 6 for an upper GI tract. We also get terrestrial activity from outer space at 0.21 millisieverts. Cosmic radiation for living at the sea level is 0.3 millisieverts, 0.8 millisieverts for living at high elevation in Denver. Radon in-house gives you up to 2.28 millisieverts in a year, and living near a nuclear power station gives you less than 0.01 millisieverts in a year. So you are being exposed to radiation without even thinking about it. If you have a doctor that wants to operate on your back and ask to take an x-ray, you'll probably allow it. You want to do the same thing for a dentist. Do you want a dentist drilling on a tooth without seeing how far the decay goes or how close it is to the nerve? It is your job as a dental assistant radiographer to educate your patient. Try to put yourself in the patient's shoes and be compassionate about their fears. Explain the ways that we protect them by using techniques to limit radiation and by the use of lead aprons. Once they realize that you care about their safety and that we are only taking the necessary x-rays to diagnose, then they will be more likely to agree to have x-rays taken. To understand where the term X-radiation comes from, we must have an understanding of what ionizing radiation is and what atoms are. Atoms are a fundamental piece of matter. They are what make up all the particles around us, from graphite in our pencil, the water in our bottles, to the food that we ingest. There are atoms all around us. How tightly they are condensed is what gives us the states of matter. Atoms have their own building pieces that are called subatomic particles. So there are protons, neutrons, and electrons. Is this sounding familiar from your high school days? There is a center part of the atom. This is where the neutrons and the protons hang out. The protons have a positive charge, neutrons are neutral, and circling around the positively charged nucleus on what we call orbits are electrons. Electrons are negative. You can remember that it would be negative to be shocked by electricity. What can happen is an electron on an orbit becomes displaced. We are not sure why it was displaced. All we know is an outer electron on an outer row is moving forward, exerting energy. Just like you would get up from a movie theater because you saw someone move and you want to be closer to the stage, then you'd have to exert some sort of energy to get up and get there. What is interesting is that these atoms are subatomic particles that were discovered back in 1911 by Ernest Rutherford based on a 1909 Geiger-Mazdin gold foil experiment. The energy that is released, we found out then that the energy that is released of the 99% of the energy is lost to heat, and only 1% is used to create this X radiation. What happens is this 1% creating the X-rays, the displaced or ejected electron then creates a ripple effect and it interacts with all these different atoms around it at lower energy levels. You drop one electron and it hits another that hits another, and the ripple effect creates X radiation. To be considered ionizing radiation, it has to be strong enough to detach electrons from molecules. So we're trying to figure out, where is this ionizing radiation coming from? Where is this lone electron, that has come flying over to the ejected one from the molecule? Where did it come from? To figure that out, we need to look inside the tube head. Here we have an illustration of the tube head. This is where the X radiation is being produced. Inside the tube head, there's a Pyrex glass vacuum tube, and it has two different parts to it. On one end has the cathode that is fixed. On the other end is the anode that is fixed. The cathode is negatively charged and the anode is positively charged. Think of it as it's negative to get a C on an exam and positive to get an A. When we are creating all of these displaced electrons and X radiation, it creates a lot of heat. Remember, 99% of this energy is lost to heat and only 1% is used to create the X radiation. So surrounding this Pyrex glass vacuum tube is insulating oil that will help to cool it down so it doesn't overheat. When we push the exposure button, 60,000 volts of energy is sent through the negatively charged cathode on what we call the tungsten filament. Tungsten is an interesting metal. It is also known as wolfram. It is on the periodic table with the atomic number 74, and its original Swedish name means heavy stone. It has the highest melting point and the lowest vapor pressure of all metals, and even at the temperature over 1,650 degrees Celsius, it still has the highest strength, excellent corrosion resistance, and mineral acids don't do much to it. It can withstand a lot of heat and pressure. When it heats up this filament, it causes the outside surface of the oxide coating to then emit electrons. Now remember, the cathode already has a negative charge, and the electrons have a negative charge. Do you think that the two negatively charged items want to hang out together? No, it's going to repel it at a really high speed. It shoots over to the positively charged anode. Opposites attract, right? So negative electrons are attracted to the positive anode. Think if you get a C on an exam, you want to shoot towards an A. So from the negative charged cathode, the electrons are emitted and they are attracted to the positively charged anode, and it strikes what we call the tungsten target. The tungsten target is where ionization occurs, and we displace electrons and create the X radiation. You'll notice that the anode has an angle to it. It's so that it will direct the different wavelengths. Think back to the electromagnetic spectrum for a second. In X-rays, there's not one size of wavelengths. There's shorter wavelengths with higher penetrating power and longer ones with less penetrating power. So those wavelengths pass through the aluminum disc or filter. The filter then absorbs the low energy long wavelengths or photons and allow the high energy short wavelengths to pass through. We don't want the low energy ones because they don't have enough power to get through the tissue and the teeth and to strike the sensor to create a wonderful image. We want higher energy wavelengths, but we don't want these wavelengths spraying all over the face. So we use what's called the lead collimator. The lead collimator takes this and centralizes it into one primary beam. Then it goes through the PID, which stands for Position Indicator Device. The PID then directs the beam where it needs to go. So I know this is a lot of technical terms, but hopefully this gives you a better understanding of what is going on inside of the tube head. Even though the discovery of X-rays date back to over 120 years ago and have grown in leaps and bounds in technology since then, the science behind it has remained constant. To begin the process of creating this image, you have to first push the exposure button. Nothing will happen unless you push the button. This means that you can turn on the X-ray unit when you get to the dental office in the morning and leave it on all day without worrying about constant exposure. Nothing happens until you push the exposure button. Once you push it, then you send the 60,000 volts of energy through the tungsten filament of the cathode. It starts to emit the negatively charged electrons that are drawn to the positively charged anode and hits the tungsten target and displaces electrons. It creates this chaos there. It creates this ripple effect where one electron hits another electron and so forth. It creates a spectrum of wavelengths, some long and some short. The shorter wavelengths are filtered out by the aluminum discs, and it is centralized by the lead collimator, and it passes through the PID. Once it passes through the PID, then it passes through the object we are wanting to get an image of. In our case, it's the tooth. But with Wilhelm Conrad Röntgen, the first image was of his wife's hand. Now I always get the question, what is the big bump on her finger? After doing some research, we found out that it was just her wedding ring. Pretty anticlimactic. This is the first medical X-ray in history. It looks not much better than a shadow puppet that you would do on a wall with your kids. But that is essentially what we are doing. We are creating a shadow graph, but instead of using the light radiation or the visible light that is lower on the electromagnetic spectrum, that doesn't have enough penetrating power to get through your skin, we are using a little bit of a higher penetrating power, the X-rays that have enough penetrating power to get through tooth and tissue, that can pass through the soft and hard surfaces to project this image not on the wall but on the film or the sensor. It's interesting that dentistry is ever evolving and changing, but the original science dates back to 100 years ago. Actually more than 120 years ago. Moving on to Module 2, Let's discuss the settings that will affect the outcomes of your images. Even though the settings are calibrated, they shouldn't remain the same all day. If we are adhering to the ALERA concept, which means as low as reasonably achievable, which means we're promising to only take the x-rays that are absolutely necessary so that we don't expose any patient to excess radiation. So we should make sure that the settings and the number of images should be switched depending on the conditions of the patient. We need to really look in the patient's mouth to see if we can eliminate some x-rays because maybe their mouth is smaller. Are the settings still set the same for your last patient that might have been larger? You don't need the same penetrating power on a small child that you would on an adult. You have to protect your patient from unnecessary radiation. Let's take a look at these settings. What does it mean when we are switching the settings from adult to child or from anterior tooth to posterior teeth? So we are looking at the settings and what they do when you change them. So back in the day, we used to have to manually change the settings. So we would have to set the milliamperage or the MAs at one thing. We'd have to change the kilovoltage peak and the time. We'd have to do that manually. Now they've made it pretty dummy proof where if you're taking a picture of a molar, you simply put the button of the picture with the molar in the picture. If you're taking an anterior tooth, you push the button with the anterior tooth, and so on. But it's really important that we understand what the settings are and why it's important that we change them on each patient. So milliamperage or MA and the exposure time in seconds determine the number of electrons passing through the cathode filament and for how long. Increasing either of these settings will increase the photons created and for how long they will be exposed, thus increasing the density or darkness of an image. If you decrease that, you get a lighter image or less dense image. Kilovoltage peak affects the wavelength and the penetrating power of the beam. If you increase the kVp, it will be stronger and will decrease the time or the contrast between the different objects' densities. So it will be able to penetrate all densities equally versus low energy that can't penetrate metal as well as dentin, for example. Let's try to make sense of the kilovoltage peak. Let's say you're sitting out in the sun reading a book. You drift off to sleep. You forgot to put sunscreen on and you wake up to notice that your body is burnt. Now you have a really funny tan line because where that dense book was sitting on your lap, the UV rays didn't have enough penetrating power to pass through the book. So now you have a white spot in the shape of a book on your lap. Even though your body was exposed equally to the UV rays, they didn't have the penetrating power to get through the book. If you increase the kVp or the penetrating power, then we wouldn't see a difference where the book was because there would be no contrast. We need to make sure that we have the settings correct so that we have good density and good contrast so that we can tell the difference between dentin, the pulp cavity, the enamel, tooth decay, and different pathology that we want to identify with the changing of the settings. The settings should never be kept the same on all patients. Just as you don't need the same penetrating power as a child, as an adult, you don't need the same penetrating power on an edentulous patient as a patient with a full set of teeth. Part of adhering to the ALERA concept is to make sure that we treat each patient as an individual. This means looking in their medical history, in their charts, and in their mouth. We are trying to evaluate what this particular patient needs. Just because they are on the schedule for a full mouth series of x-rays doesn't mean that you just blindly start taking x-rays. If you look in the patient's mouth and notice that they are edentulous, it would be better for the patient to take a Panorex instead of a full mouth series. Why would we need an x-ray for someone who doesn't have teeth? We are trying to evaluate their bone density. It could be used to treatment plan implant supported restorations like dentures, or it can be used to evaluate or look for the possibility of impacted roots or teeth. Every once in a while, a patient will come in and you'll look in their mouth and it may appear that they don't have any teeth. But then when you take a Panorex, you'll notice that there are existing roots embedded in their gum line. So what happens is a tooth decays, and so the crown portion of the tooth that we would see when we look in the mouth is no longer present, but that doesn't mean that the root is not still there. So it's very important to look in the mouth, and then it's equally as important to take an x-ray to really evaluate what's there and what's not. If it's a pediatric patient, they only have 20 teeth, so instead of taking a full mouth series of x-rays, bite wings are a better option, either one on each side or two on each side, depending on the size of the patient's mouth. If the patient is healthy, they have healthy gums with no noticeable decay, then 4 bite wings and a Panorex is a better option. So it's super important that we evaluate and treat each patient like an individual. When we look at these pictures on the screen, evaluating a patient's anatomy is equally as important. In these pictures, we have tori palatinius or tori mandibularis, which is just a hard bone structure on the palate or on the mandibular. When you're taking images with a sensor or a film, you have to be very careful because if you place them on top of these tori, they might cause a lot of pain, which might mean that you need to take an external x-ray instead of the internal x-ray that you would normally take. So when you have a patient, instead of just going by what is on the schedule, really do your research to make sure that you're doing what's best for that individual. We don't only need to evaluate a patient to determine what type of x-rays that this patient needs, but also to determine what type of approach that you will need to take for this individual. Some patients are super comfortable at the dental office, while others are very anxious. On an anxious patient, we will need to take the time to explain what we are doing and to put them at ease. Confidence and efficiency are two of the best attributes of a dental assistant radiographer. In addition, encouraging your patient along the way makes the process of taking x-rays a little bit easier on everyone. In regards to a patient that gags, be empathetic and work quickly. Encourage the patient to breathe through their nose and to keep their eyes open. It's helpful to have them focus on something across the room, maybe a point on the wall. Gagging is triggered on the soft palate in the back of the tongue. Gently but firmly place the x-ray against the tissue, avoiding the triggered areas. Start on the anterior images to demonstrate that the patient can in fact get through this and that you will move efficiently. This gives the patient confidence that they can do it. There are different techniques when taking radiographic images. Most dental assisting radiographers utilize the paralleling technique. It's the best technique or the preferred technique because it eliminates distortion, so it represents an accurate representation of the anatomy of the tooth. Whenever possible, what the paralleling technique relies on is to first make sure that the ala tragus line is parallel to the floor. You can see this in the image on the left. You can see that the nose and the ear, or the occlusal plane of the mouth, is parallel to the floor. So you also need to have the tooth and the film or the sensor parallel with each other, hence the name, the paralleling technique. If the patient has a shallow palate or tori, or if they are a gagger, this technique might not be feasible. So it doesn't work on every single patient, but otherwise, this is the quickest and easiest technique. Visualize that the tooth has an axis running right down the center. We want to make sure that our film or our sensor, which is labeled receptor on the diagram, which is whatever is receiving the image, runs parallel to that central axis. We don't want to see bending of the film or tipping of the sensor, which sometimes happens because of the anatomy of the patient's mouth. The reason we do this is so that the x-ray, the central ray, can strike the central axis of the tooth and the receptor at the perfect 90-degree angle, which eliminates any kind of magnification or distortion that can come from the receptor tilting or turning. You really want to make sure with this paralleling technique that everything is in line when you have the patient carefully and slowly close together so that you can line up your tube head and take your image. Although our preferred technique is the paralleling technique when taking dental radiographs, it is not always possible. If we are unable to get the receptor and the tooth parallel, then we need to use the bisecting the angle technique. This technique is not as accurate and not as foolproof as the paralleling technique, but it might sometimes be our only option. In this technique, you have to account for the extra angle of the receptor. So if they bite and the film tilts excessively instead of lining up with the receptor at a 90-degree angle, or lining up to the central axis of the tooth at a 90-degree angle, then we have to cut the angle between that in half. This takes some visualization here in a different film holding device. We line it up with a 90-degree angle to the imaginary bisector. This is really tricky to get, but it allows you to free yourself of the constraints of the RIN, even though the paralleling is preferred and has the least amount of distortion. If we only rely on the paralleling technique and get into the patient's mouth where it's not working, we are going to end up with either a foreshortened or elongated image. When talking about object film distance, you have a source of radiation, the object, and the receptor. So going back to the shadow puppet example, which is the same as taking an X-ray, you would have the source of radiation as the flashlight, the object would be your hand, and the receptor would be the wall. So keeping your flashlight mounted on the table, meaning it can't move, obviously you don't move the wall. If you take your hand and place it near the wall, your hand looks pretty accurate in size and shape. If you move your hand away from the wall and closer to the source of radiation, which is the flashlight, the image gets magnified and becomes distorted on the receptor or on the wall. The same thing can happen with X-rays. If we were to make the X-ray and film constant, but the tooth and the source of radiation are closer than the tooth is to the film, then you're going to have magnification or distortion. So what you really want to do here is the object and the film needs to be close to each other, just like your hand and the wall, to make a clear image. Although it is extremely important to get a great image when taking X-rays, it is also top priority to do so safely. You must take precautions to protect yourself and your patient from radiation. Anytime you expose someone to X radiation, different radiation affects the body biologically different. For example, if you were exposed to high levels of radiation, maybe you were close to an atomic blast, you could experience acute health effects such as skin burns, acute radiation syndrome, radiation sickness. You may also experience long-term effects such as cancer and cardiovascular disease. We call these somatic mutations, meaning they affect the individual's long-term health, for example, cancer. There are also genetic mutations which affect children and young adults who are more sensitive to radiation. These can damage the DNA in our cells. Genetic mutation can be transferred to the next generation. When we take special precautions and follow the ALARA concept, again as review, the ALARA concept is as low as reasonably achievable. We are preventing both of these mutations from happening, both somatic and genetic. Making sure settings are correct, checking medical history and charts. Are they already going through radiation therapy? Did we already take these X-rays the last time that they were in? All of these things are protecting our patients and ourselves from these mutations. Patient protection includes making sure your settings are correct, only taking the necessary images, using the proper technique so we can avoid errors and having to retake film. Those are all included in the ALARA concept. In addition to that, Patient protection includes wearing a lead apron or having the patient wear a lead apron and a thyroid collar. This lead apron should be no thinner than 0.25 millimeters of lead to protect the reproductive organs that are rapidly reproducing cells and the thyroid gland. Patients should safely tuck their hands under the lead apron and close their eyes because the retina is susceptible to X radiation. We need to make sure our equipment is working, our licenses are up to date, and we're doing all that we can to protect the patient, but we can't forget the infection control aspect. This means disinfecting the lead apron, putting barriers on the exposure button and on the tube head and sensor, and wearing our personal protective equipment. Information coming from the Center of Disease Control and Prevention, or the CDC, says exposure of a fetus to radiation is referred to as prenatal radiation exposure. This occurs when the abdomen of a pregnant woman is exposed to radiation from outside of her body, or if they accidentally swallow or breathe in radioactive materials that are then absorbed into the bloodstream. From their blood, the radioactive materials may pass through their umbilical cord to the baby or even concentrate in areas near the womb, such as the urinary bladder, and expose the baby to radiation. But for us, we are using the electromagnetic radiation that wouldn't be ingested, but would be exposure to the abdomen. The possibility of severe health effects really does depend on the gestational age of the baby at the time of exposure and the amount of radiation it is exposed to. Although unborn babies are less sensitive to radiation during certain stages of pregnancy than others, fetuses are particularly sensitive to radiation during week 2 through 18 of the pregnancy, which is the first trimester. The health consequences to prenatal exposure can be severe. It can stunt growth, cause deformities, and abnormal brain function. Usually the baby is shielded by the mother's abdomen, so it's particularly protected, but they should avoid radiation unless absolutely necessary. Researchers agree that the unborn baby who receives a small dose of radiation have a slightly higher chance of getting cancer later in life. But during the first 2 weeks of pregnancy, the radiation-related health effects is at the greatest concern to cause death of the baby. Because at this time the baby is only made up of a few cells, damage of just one cell can cause the baby's death even before the mother knows she's pregnant. We need to really weigh the risk-benefit ratio when determining whether or not to take an X-ray on a pregnant mother. If it's simply an annual checkup, X-rays can wait until after the baby is born. If the mom has severe infection and we need to determine which tooth is infected, then we would take one PA because the infection is now more harmful to the fetus than the X-ray. According to the Nuclear Regulatory Commission, who regulates the maximum permissible dose that workers are allowed to be exposed to, states that you can have 5 REMs or 50 millisieverts a year. We want you to take precautions that you aren't being exposed to excess radiation. This is actually pretty simple to do in the dental office. You have the ability to step out of the room, unless of course you're using a handheld tube head. If you're using a handheld, you're going to wear a lead-lined apron. You don't ever hold the film in a patient's mouth, and you stand directly behind at a 90-degree angle to the sensor. But otherwise, you can step out of the room behind a wall. If there aren't any walls to physically stand behind, then you want to make sure that you are standing at least 6 feet away and at a 45-degree angle from the primary exiting beam as shown in this picture. Certain industries require you to wear monitoring badges, but in dentistry, it is not required because of the low dose of radiation that we're exposed to. Different countries measure radiation differently. In the US, we use REM and RAD to measure the absorbed doses, and the rest of the world uses sieverts and gray. When we discuss infection control, we always discuss universal precautions. Universal precautions are treating every person and every bodily fluid as potentially infectious. Whether it's your family member or a random patient, we need to wear our PPEs or our personal protective equipment um, and disinfect and dispose of things properly. Different viruses can live or remain on surfaces for several hours. Cold and flu virus droplets can remain infectious for several hours depending on where they fall. They remain active longer on hard surfaces than they would on fabrics or soft surfaces. Factors that affect this are the amount of the virus present, the temperature and humidity of the environment, and how long the virus has been outside the body. It is possible to contract diseases and viruses when handling an object that has been infected by a person's sneeze, cough, or bled on. The mode of transmission can come from shaking infected person's hand or getting exposed to droplets from a person's cough or sneeze, but it can be from these touch, spray, or splatter surfaces also. If you are using one-use products such as masks, gloves, cotton rolls, barriers, these types of things, they have to be thrown away after every use. Please do not spin barriers, flip them inside out, or use the same mask with multiple patients. Your personal protective equipment, gloves, masks, safety eyewear, are required by OSHA to be provided to the employee at no cost. When we are working with reusable items that can withstand heat, they will go in the autoclave after every use to be sterilized at 270 Fahrenheit or hotter. These things are such items as dental instruments and film holding devices. Items that are not disposable and can't go in the autoclave, such as the sensor, need to have a barrier that can be discarded after every patient to prevent cross-contamination. On hard surfaces, such as countertops, we have to use an FDA-approved iodophor or sodium hypochlorite, which is bleach water. The exposure button, lead apron, holding devices, and the tube head all need to be disinfected and or sterilized or use barriers to protect them from being exposed to saliva. On this slide, you can see an example of things that will need a barrier. Don't forget that when you're charting on a computer, you'll notice that you've got your hands in a patient's mouth, whether you're taking x-rays or doing periodontal probing, and then you're going to the computer and you're typing the information in. You're transmitting saliva from that patient's mouth to the keyboard or to the mouse or to the outside buttons of the x-ray exposure buttons, or when you slide off the barrier off a sensor, you're touching the cord with maybe your gloves that have saliva on them. So really be aware of what you're touching and make sure all of those things have a barrier, especially the items that you can't necessarily wipe down with the wipes or put in the autoclave. So if you can, when you can, cover all these items so that you can protect them from being contaminated with saliva. We're doing this to prevent the spread of infection from one person to another. This is a little side note when we're discussing the prevention of the spread of infection. Have you ever used these particular digital sensor holders that have the rubber fittings on them and open them after they come out of the autoclave and they smell just horrible? Well, we called the manufacturer and asked them about it, and they said that when you place them in the ultrasonic, it makes the rubberized pieces smell. So what they suggested is taking this particular style with the rubber on them and putting them in warm soapy water and letting them soak for a little bit to prevent bacteria causing odor in these pieces, and then putting them in the autoclave and sterilizing them just like normal. Moving on to discuss digital radiography. As conventional film continues to be reduced in use significantly, Digital imaging continues to improve and get better than ever. Digital radiographs were first introduced in the late 1980s. Compared to film, it offers 256 shades of gray, while film offers 16 to 25 shades. If you have ever worked with both film and digital, you are well aware of its benefits, but let's go ahead and review some of its advantages. Let's talk about the cone beam computed tomography, or the CBCT. This technology has advanced in the last decade. It's allowing both general and specialty practices to utilize it for many different reasons. These scans offer clear and detailed images in both two-dimensional and three-dimensional views. It allows us to manipulate, measure, and use it for a lot of different purposes, including diagnosing on patients, and also educating patients. Because we can manipulate it, we can turn it how we want to, we can show different parts of the oral anatomy, and we can color code it. It just allows us to communicate with the patient easily. And because it's in 3D, or we can use it in the 3D image, the patient can obviously understand what part of the mouth we're talking about. And so it just makes communicating that much easier. The cone beam is less radiation than a medical CT scan. I think it looks like a CT scan, like you would go and get a CT scan of your heart or some other part of your body. But it's actually less radiation than a medical CT scan. These scans are pretty quick and easy. They last only about 8 to 10 seconds. The only downfall is really for the doctor or the owner of the practice, and not necessarily as a patient, but it's the cost. It's very expensive, and it's an investment that you would probably be paying off for a very long time. I think we'd be surprised that some of us buy a house for the same amount of money as one of these. While your patient is seated or standing, depending on the positioning of your machine, your short scan begins. Depending on the design of your machine, you can get different fields of view. The narrow field of view is typically for endodontics. It allows for better spatial resolution for periodontal ligament spaces, lamina dura, root fractures, and root canal morphology. The medium field of view is typically for temporomandibular joints, and it allows for a panoramic view, whereas the large field of view is for craniofacial and a skeleton view. The different field of views are designed to benefit the different fields of dentistry. As the scan begins, it takes what we call a scout view, which allows you to look at the field of view prior to exposure, just to make sure that you are getting the view or information that you want. This minimizes unnecessary retakes and radiation exposure to the patient. It then rotates 180 to 360 degrees around the head, producing the cone-shaped X-ray beam, which creates 150 to 600 2D images for the basis images, which will later be reconstructed with this high-tech piece of software. Depending on which machine, but there might be some peripheral distortion. Let's look at what some of these images look like. Depending on what detector the equipment has, the CCD versus a flat panel, the CCD renders more of a spherical image, whereas the flat panel gives you less distortion on the peripheral edges. The rendering can be chosen based on the specific needs of the practice and the personal preferences of the doctor. You might be wondering how we are able to create a 3D or a cone-shaped X-ray beam on something that falls within the electromagnetic spectrum. We are still using X radiation that travels with wavelengths, but we are using it 3 different directions to give us that 3D image. Remember, we get anywhere between 150 to 600 2D images that are pieced together. Dedicated software will assemble all of these images into the 3D rendering. The axial portion takes images from below, starting at the chin and working up to the top. The coronal portion start from the back of the head and work around to the front of the face. The sagittal starts from side to side, moving from one ear to the next. They are all pieced together to give us that perfect 3D image. As we've mentioned before, one of the benefits of using the cone beam technology is that you can utilize it for multiple different things. This image that we're looking at here is something called a pseudo-panoramic. This is more helpful than a regular 2D pan because the teeth are not being superimposed or overlapping. In this image, we are able to see the impacted wisdom teeth, where they are related to the sinus and to the jawbone, as well as being able to see the details of the root canals on tooth number 12 and 13. How does the software work to create the three-dimensional image? It's what we call voxels, which are similar to pixels for the 2D images. They are the smallest 3D element. The smaller the voxel, the better the quality. Since the voxel is isotropic, meaning it has the same properties when measured in all directions, the image will be super accurate. When discussing the benefits of digital radiology, we oftentimes compare it to film X-rays. Here are some comparisons between the two. Digital radiology, or the use of a sensor, uses 80% less radiation than our fastest speed of film. The benefit of using a sensor is that we don't have to switch film every single picture. We simply use one sensor and move it around the mouth to take as many images as we want. We don't have to use processing chemicals. When developing film, the chemicals were always wrong or dirty, not enough, not the right temperature, and they caused a bad product when taking X-rays. There's no risk of double exposure. In digital imaging, the contrast is the differences in shades of grays. It depends on what is called the bit depth, or the possible shades of gray that an image can store. For example, 1-bit images only allow 2 values of gray to be stored. 8-bit images allow 256 possible shades of gray values. A 12-bit image allows 4,096 different shades of gray that can be stored there. I didn't ever realize how many shades of gray there actually are. It has a lot of ability to create a more contrasted and detailed image. The one benefit that is truly amazing if you've ever taken film X-rays is that the image is immediate. It can also be manipulated. We're not changing its appearance, but we're actually manipulating it so that we can see it better. You can measure on it, email it, print it. It's just super convenient. There are a few downsides to a digital sensor using digital radiology, and the first one is the investment of it. One digital sensor costs anywhere between $6,000 and $15,000 per sensor. And that's just if you have one. Most offices need multiple sensors for multiple hygienists and different operatories. And the second downside is that they're very fragile. We have to be super careful not to drop the sensor or to step on it or to have the patient bite on the cord. We have to treat this digital sensor like it is our newborn baby. I like to think of indirect digital as a step between conventional film and the digital sensor. Think of it like using a memory card on a digital camera. You have to take the image and then download it. The phosphor storage plates store the image in phosphor, which is a metalloid, which means not really a liquid and not really a solid. You store the image and then download it, so it doesn't require any processing chemicals like a conventional film. They are actually more detailed. You can see more spatial resolution and fine details compared to the digital sensors. Unfortunately, these can be damaged or accidentally thrown away. You have to use a new phosphor plate for every image. So when taking a full mouth series, you would need 18 phosphor plates. When you download the image or images, you can reset them or essentially delete the image off of them and then reuse them on the next patient. They are thinner and more comfortable than a digital sensor, but you have the added steps of switching each plate for each image and then downloading. They also don't last a long time. The phosphor plates can only be used for about 48 images before they start to wear out. In Module 6, we're going to refresh your memory on the radiology laws that govern you. Let's go ahead and go over them now. In the state of Ohio, you must keep your radiology license current. You need to renew every even year with proof of 2 hours of continuing education. You absolutely cannot take x-rays without a valid license under the Ohio Revised Code. There are a lot of resources for us as dental assisting radiographers to keep updated on all the new and current laws. Some of those are the State Dental Practice Act, or ada.org, or the State Dental Board's website. You are probably aware of the difference between direct and indirect supervision, but let's review for just a second. Direct supervision are the things that the doctor gives you to do while they are physically present in the dental office. Indirect supervision are things that the doctor can direct you to do when they are not physically in the office. So the indirect supervision laws allow us to perform radiologic procedures when the dentist is not present under the following parameters. 1, the patient has to be a patient of record, meaning they can't be a new patient. 2, the dentist has to have performed an exam on the patient not more than 1 year prior. And number 3, the supervising dentist has to order the radiologic procedure to be done. With all the hacking of information going around in our world right now, it's more important than ever that we protect our patients in this digital age that we're living in. We need to back up all the files on an external hard drive or a server. We need to put firewalls and passwords in place. We need to control access to information. We have lots of people in and out of our dental office, from the cleaning people to the staff on site to vendors and all of the different areas of the dental office. If we're using vendors, they should sign and agree to protect the patient's information. This is very important. We do not want to use unsecured email servers when sending emails back and forth. Instead, we should be using encrypted formats or a zipped file to get that information to and from without exposing any of the privacy information that we store with our patients. Ionizing X radiation is created within the tube head once the exposure button is pressed. This means that when we come in the dental office in the morning, we can go ahead and go through all of our operatories and turn on our dental X-ray units for the day without worrying that we will be exposed to X radiation, because we know that nothing happens until we push that button. Since this radiation is higher on the electromagnetic spectrum, they have higher penetrating power and could potentially cause genetic or somatic changes. That means that when we're taking x-rays on our patient, we are going to follow the ALARA concept, meaning we're going to use as little X radiation as possible. We're going to pick the right setting so that we are not using a molar amount of penetrating power when we're taking a premolar, or we're changing the setting from an adult to a child so that we're not using a large man size penetrating power on a small child. And know that if we take an x-ray that we don't really love, but it will pass as far as being clinically able to read it, we're not simply going to just willy-nilly take over a zillion x-rays on this patient simply to get the perfect thing. We know that when we're taking x-rays, it's causing genetic or somatic changes at a cellular level on our patient. So we're going to do this wisely. To minimize the risk to patients, we're going to continue to follow the ALARA concept, taking images in the correct settings and only when medically necessary. In conclusion, part 2. The paralleling technique is the image taken with the least amount of distortion. This is actually what we are doing when we're using a RIN. It holds the film, the source, or the object that we're trying to take an image of, and the PID all parallel to each other, which creates a perfectly perfect x-ray every time. You must obtain 2 hours of continuing education related to dental radiology every even year and renew your license on elicense.ohio.gov. So your certificate from today's course will fulfill your 2-hour CE. So what you're going to do is just print it and upload it to your elicense.ohio.gov, and you will be good for another 2 years. To protect the patient's information, do not open emails from unknown senders. Do not email files over an unsecured email server, and have a firewall in place to prevent hackers. Thank you so much for taking our course today. We appreciate you. We know that you could go anywhere for your continuing education needs, but we sure love to have you. I hope you have a wonderful day, and we'll see you next time. Bye-bye.